Thank you for everybody for coming. Today, I've been talking about Snoasis, and since this is a corporate forum, we can use names, BioXclude, for over 10 years now. And literally from when there was 2 people, at the company. And so what I'm showing in the lecture today is how my use of this product has changed over 10 years of practice. And this month has been a very busy month. Beginning of the month, I was giving some lectures in South Africa, and then last week in Las Vegas, and now here in freezing cold Chicago. And I'm from Texas, so this is pretty cold for me. So in 10 years of practice, I started with a traditional perio practice, and then over time that got more and more to an implant-based practice. And for quite a while now, my office has been pretty much a full arch implant practice. And the way that I've used this product over time has changed during that 10-year period. So what we'll be talking about is dehydrated human Amnion-Chorion membrane, which is BioXclude. And we can say it's BioXclude because the only Amnion-Chorion product in the dental industry is BioXclude, and that's because of patents and distribution rights. And so any other placental-based product in the dental market, they are only amnion products. And we'll show the difference between amnion and chorion and why the chorion gives significant benefits over amnion alone. So what is the Amnion-Chorion? Well, the Amnion-Chorion is the avascular layer that separates the mother from the fetus, with the amnion being the closest layer to the fetus. Boy, this screen is like really close. And the chorion being the at the maternal decidual interface. And so this tissue is taken, the placental tissue is taken from mothers that are having C-sections, all consenting, of course. And then the tissues are quarantined and then processed in the same manner that all other tissues are processed with the AATB. Now, with the tissues that BioXclude uses, they come from a company called Mimetics, and they undergo a very proprietary specific processing called Purion processing. And we're going to have a lot more detail on the science in the next lecture, but some very basics. This is deepithelialized. The spongy layer is removed, and then the amnion and the chorion are laminated together. And that's how we end up with our DHACM or BioXclude. So in this product, there are over 200 plus growth factors, chemokines, cytokines. And I remember when I first started lecturing about this, I think they had identified somewhere in the range of 50 plus. And as they've done more science and more research into this, now we're well over 200 plus factors that we've identified in this product. So I've mentioned a few times that these are amnion and chorion. And what are some of the benefits of combining the two? Well, in most other products on the market with an amnion-only product undergoing a non-Purion processing, you're retaining about 5% of the growth factor preservation in amnion. In the Purion processing, that can be increased to about 20%. But when you're adding in the chorion, this is where about 80% of the growth factors are. And so when you have an amnion and chorion product, we can see the blue is the amnion. The majority of the growth factors are in the chorion. And so it's interesting because there's been this rise of placental products on the market, and a lot of other companies that are marketing some of the placental products, because they're amnion only, they almost try to make it sound like having the chorion is a bad thing. And if you look at their advertising, that's almost the impression that they give. Well, if you look at any of the actual science behind this, the majority of the growth factors are in the chorion. The chorion also, if we're using this as a membrane, gives us some thickness, a pretty substantial increase in thickness. And I remember when I first started lecturing on this, especially at the perio meetings, because we're so science-based, we have a lot of clinicians that would ask, well, where's the science behind this? Where's the published studies? And at the time, there weren't very many published studies. Now, there are 40+ published studies on this material. And on the amnion-only products, there's only a very tiny, tiny number of studies. And so if someone is showing you an amnion-only product, do what people did to me 10 years ago. Ask them, where's the studies? Where's the data behind your amnion-only product? What about the Chorion having 80% of the growth factors, 20 times more growth factors? And I'd be curious to see what they say. So Amnion-Chorion's been used in medicine for well over 100 years. The first published articles on placental-based tissues were in 1910, and these were used for skin transplantation. In the 40s, they were used for treatment of conjunctival epithelial defects. In the 60s, they were used in ENT surgery. And even way back then, what they noticed was there was a lack of infection, there was decreased pain, and there was increased rates of epithelialization. Now, over the past 20 years, this particular product, DHACM, has exploded in use, and one of the significant reasons was because of healing of non-healing diabetic foot ulcers. Now, as you know, when these don't heal, this is one of the reasons that there's a lot of amputations with poorly controlled diabetics. And I was in the military for 13 years, and we have a large military contingent here, thank you. And during that time, this was during the height of Iraq and Afghanistan, and we do quite a bit of anesthesia training in our program, anywhere from 3 to 4 months of anesthesia training. And during that time, I saw a lot of amputations, and it's not a fun thing, especially, it's just a lot for the person to go through, a lot for their family to go through. So when this came out and it was allowing a lot of these patients with non-healing diabetic ulcers to avoid amputations, that was huge. And so in the medical market, this exploded. And then this is being used for other items, such as wrapping neurovascular bundles during prostate surgery. And when this is happening, we're having improved return time to continence by 50%, improve erectile dysfunction changes by up to 90%. And so this is now becoming more standard in prostate surgery. Also in Mohs micrographic surgeries. So for example, treatment of basal cell carcinomas. My wife has had this done, and I gave the dermatologist some BioXclude to use for her case, and it turned out very well. But I mean, if we think doing a connected tissue graft on tooth number 9 in the aesthetic zone is challenging, I mean, imagine what these doctors are having to go through. There's really nowhere to hide this. And we can see with some of these surgeries, utilizing the Amnion-Chorion, they're getting some very impressive results. So how has Amnion-Chorion been used in dentistry? So it's been in dentistry now for about 10 years. And over that 10-year period of time, it's been used to treat recession defects, site preservation, guided tissue regeneration, treatment of peri-implantitis, guided bone regeneration, sinus lift repair, and a whole number of other items. When this product very first came out, the only thing it was being used for was treatment of recession defect. That was it. In the very first iteration of this product, when it was amnion only, to be blunt, it sucked. And I told the CEO of the company that, and about a year later, he came back and said, hey, we have a new version of the product. We've added the Chorion, and ever since that, it's been night and day. And we've now expanded this use to all of these different uses. And even back when this was done, I remember Paul Rosen and I were doing some of the very first ones, and we would just call each other on the phone, and we'd be talking on the phone and say, hey, have you tried it for this? And we were like, no, I haven't tried it. So, well, I did this, maybe it'll work there. So we'd try it and we'd share cases back and forth. And then from there, this expanded to quite a few other uses. So just a little bit of science behind here, because we're going to have more in the next lecture. But with our traditional membranes, we've always been taught they act as a wall to keep things out. And we're wanting to keep out fast-moving epithelial cells so we can allow our wound defect to repopulate with cells from the cementum, PDL, bone, so we can get regeneration. Well, with this product, it is acting more like a growth factor than a barrier. Because of the matrix component to this and the high amounts of laminin and laminin 5, the epithelial cells literally skip across the BioXclude matrix almost like a rock skipping across a pond. And you may say to yourself, well, wait a minute, we don't want epithelial cells into a bony defect. Well, because this is rapidly migrating across so quickly, you are getting a natural seal across your bone graft, and once those epithelial cells reach each other and have contact inhibition, you now have your natural seal. The rest of the BioXclude begins to break down and is releasing all the other growth factors into your graft. So it is functioning quite a bit differently than a traditional membrane. The handling of this is a little bit different as well. The thickness is quite a bit thinner. It's about 300 microns thick, where the typical membrane, collagen membranes, anywhere from 750 to 1,000 microns thick. These membranes are self-adherent. They can overlap upon one another. They can touch the root surface. They can be left exposed to the oral environment. So that's a significant benefit for this product. So when we're comparing this to traditional membranes, there are a lot of differences. So uses for this in surgical dentistry. So periodontal practice. So when I first left the military, went into perio practice, the thing that helped me grow my perio practice the fastest was guided tissue regeneration. And so guided tissue regeneration at even our perio conferences doesn't get a whole lot of attention. If you look through your program guide, how many lectures in there are on guided tissue regeneration? Not too many. However, this is what really helped my practice grow the fastest was GTR, because my practice had a whole bunch of GTR in the records, and once we started treating these cases and we started getting very good results, we started getting a lot of referrals. And as these referrals came in, then it turned into other types of cases, eventually implant cases, and then so forth and so on. So with GTR, I'm going to show us a handful of cases. So we can see here we have a fairly large defect between the molars. And so we treat this in pretty much the standard fashion. We're going to degranulate the defect. We have a nice big piece of calculus here. We clean that off. We graft the site with Allograft, place our BioXclude over the top. And if you notice, it's touching the root surface. It is not sutured. It is not specifically trimmed to adapt to the root perfectly. It is just put into place and just kind of tacked down really quick. Here we are at our baseline. Here we are at 18 months. And here we are at 84 months. So at 84 months, we can see that this has remained very stable over time. And we know after 84 months that that bone's been completely turned over many, many, many times. Quick second case of guided tissue regeneration. So as we got more and more cases, people kept sending more challenging cases saying, hey, this patient wants to save this tooth. Can you do it? And I said, well, sure, we'll give it a try. And if we tried it and it didn't work, then we always went ahead and extracted a tooth and grafted and didn't charge the patient anything because they've already paid for this surgery. And so we treat this in the same fashion. So we can see we have a very large defect that's extending into the furcation, graft with bone allograft, place our BioXclude, and here we are at baseline, here we are at 4 months, and here we are at 48 months. So a tooth that pretty much most other offices would condemn for an extraction and an implant, we were able to save. The patient was very happy, and the referring doctor was very happy, and that turned into more referrals. So we published a study in Clinical Advances in Perio in 2013, and in this study, well, it is very hard to look behind here. We found improvements of probing depths of about 5 millimeters and clinical attachment gains of about 4.7 millimeters. Now, if we compare that to previously published studies, we can see that our clinical attachment improvement and our probing depth improvements are very comparable. So even though we have this membrane that is a fraction of the thickness, that we can leave exposed, that we don't have to specifically trim, that we don't have to suture around the tooth, that we were still getting results that were very, very comparable to previously published studies. And when we were doing a lot of this GTR, the first thing I noticed was that at the first follow-up visit with traditional membranes, many times I would see a lot of the cold tissue will have died back and I could see some of the membrane. Well, with this product, when at the first follow-up visit, I would see some of the cold tissue die back, but there would now be granulation tissue in the cold area. And that, as Dr. Rose and I were talking to one another, we surmised, okay, well, that's basically a mini extraction site. And so now that has granulated and covered. And from that thought concept, we moved on to doing extractions and leaving this exposed for extractions, because at the time this was not an indication for this. So utilizing this same treatment concept, we treated some GTR for periimplantitis defects. So here we have a defect around this implant. We flap, degranulate, detoxify the surface, place bone, place our membrane. Here we're at baseline, and here we are at 16 months. It was really hard standing so close to this thing. And the other interesting thing is just looking at the tissue tone around the implant. So if we look here, you see there's minimal keratinized tissue, very thin. And just from this, we have a nice plumper band of tissue and just a better looking area of tissue around that implant. So as we began using this more for conventional implant practice, the first thing that is the most important is going to be extraction site preservation, which doesn't sound like a very sexy subject, but it's the basis for all of our implant practice. So why do we want to perform extraction site preservation? Well, we know from previously published studies from Schropp and Iacella, if you are doing site preservation, you have up to 125% more preservation of ridge width, and you have up to 244% more preservation of ridge height doing site preservation versus not doing site preservation. It really boggles my mind that I still get a lot of patients that come in and they'll have been to other specialty offices, and in many cases they'll have extractions done but no site preservation. And I can tell you, I do site preservation on just about every case unless it's a third molar. So we know tenets for site preservation. We're doing atraumatic extraction, sectioning teeth. I can tell you, section most teeth, even anterior teeth. We're then using graft placement, whether it be allograft, calcium sulfates, autografts. And then there are a number of different coverings we can use, from collagen plugs, collagen tape, PRF, EPTFE, Amnion-Chorion, and they all have advantages and disadvantages. Today we're talking about Amnion-Chorion, and so we'll run through how this is used for site preservation. Nothing groundbreaking. We're just taking out a tooth, putting in allograft, leaving our membrane exposed, and that heals with keratinized tissue, and then we have bone for implant placement. So some advantages and disadvantages of the yes?
What's the time period for that tissue to close over the extraction site at the end now?
I'll show you in a couple other slides. So some advantages over this: we can leave it exposed. We don't need primary closure. So this is a big advantage. Now, with that being said, many times when people use this for the first time, they'll be using a titanium mesh and have 15 millimeters of exposure, and they put a piece over it and they say, oh, it didn't close. I was like, well, yeah, you're putting it in the most difficult situation possible. It's like, I'm not leaving titanium mesh exposed with this. But for a standard site preservation, yes, you can. You get faster granulation coverage, increased amounts of keratinized tissue. As long as there's some keratinized tissue at the wound margins, those epithelial cells are going to migrate across the matrix and is going to heal with keratinized tissue in that area. It has proven results. There are now dozens of studies on this material. Decreased amounts of pain. Matter of fact, the very first study in Journal of Periodontology with this product, that was the finding of the study. They had decreased amounts of pain with amnion grafts. We know we have inherent growth factors, and we don't need to remove this barrier, which is something that's a big advantage over other materials. For example, PTFE, you have to go remove that barrier anywhere from 21 days after the surgery. And even though it's a very minor procedure for some patients, because I used to use PTFE in the past, I remember it was a very big deal because you had to pull that barrier out, and even though it only takes 5 seconds, for some of them, it was like you thought you were cutting off their foot. Disadvantages: increased cost compared to, say, collagen tape. However, Snoasis has decreased the cost for single site preservation, and it's now very economical for single sites with the different sizes that they've come out with. This is very thin, as I mentioned, about 300 microns. So for certain defects where we're needing space maintenance, you will need to come up with some techniques to help you with space maintenance, and we've done that over time, whether we're using tenting screws or we're using blocks or we're using a combination of membranes. There's a variety of ways that people do these, and we'll show a couple. So I'll show just a couple sample cases. It's a very simple extraction. We just section the tooth, place our allograft, place just one layer of Amnion-Chorion BioXclude, and just leave it completely open with gut suture. And for this particular case, we had the patient come back very rapidly because we wanted to document this. And so they don't all heal like this, but this was a pretty spectacular case. So this was at 48 hours. This is at 96 hours. This is at 3 weeks. And this is at 3 months. And so you can see everywhere that was exposed has healed with keratinized tissue. So another technique. So here we're losing a buccal wall. And so in this, now I've used just the Amnion-Chorion BioXclude alone. And for me, what I have found on these that work the best in my hands is I'll put a collagen membrane over the wall. Now, I don't want to advance the flap to do primary closure. I'd like to try to avoid doing any periostal release here if I can. So what I'm doing now is placing allograft and then just placing a layer of BioXclude perpendicularly over the collagen membrane, and we're just leaving that completely exposed. And so over time that heals, granulates in. We have bone formation to where we can place our implant. So if we look at before and after, we see the wall's regenerated, even though we left it completely exposed, no primary closure, no periosteal release. So in Compendium in 2014, published a series on this technique. We had 10 patients, we did histology, non-primary closure, very similar to the socket that I just showed, trephine cores. And what we found was that at an average of 14 weeks, we had about 39% vital bone formation. Also, what was not published in the study was we also took soft tissue biopsy punches and analyzed those. And anywhere that the membrane was left exposed, we had stratified squamous epithelium, keratinized gingival tissue. So if we compare this to previously published studies, literally over the past 20 years, using a variety of different materials, a variety of different barriers, some with primary closure, some without primary closure, we can see that the percent vital bone formation is very similar. So even though this study was for a shorter period of time and this was left completely exposed to the oral environment, we still had very similar amounts of bone formation. Now, many of these other studies could have had the same results in shorter amounts of time, but this just happens to be at the time that they did the reentry on their studies. We just went back in at 14 weeks compared to when they went in at in their studies. This is just with the BioXclude over the top.
Right, but the one with the star, the collagen, that 10% lost all or part of the graft, so that implies that there wasn't any of the cases that you did where you see the bone graft lost.
No, I did not have any. And to be honest, we take out close to 2,000 teeth a year in the practice, and my assistant does all the post-ops, and I've been working with her now for 10 years, and if she calls me in the room only if there's something out of the ordinary looking, and I might get called in, I don't know, 1 or 2 times in the year for one of these. And it's usually because somebody went in and tried to clean the site or do something with the site. Now, one thing that's really important for this, and we didn't know this in the beginning, was when you're doing this and leaving this exposed, you do not want to have your patients rinse with Paradex, because the Paradex will inhibit the healing of these. Now, by chance, probably just dumb luck, I didn't have my patients rinse with Paradex for extraction sites, and the reason I didn't do it was because a lot of the patients would just over-vigorously rinse and would end up rinsing a lot of the bone graft out. And so I would have them not rinse with any Paradex. I wouldn't prescribe it to them, and I was getting very good healing. And the company was calling me and saying, hey, there's a lot of clinicians, they're not getting the same healing that you're getting. I said, well, what's their protocol? And consistently, the only difference was they were using Paradex. And so I said, well, I don't use any Paradex, so have them discontinue using the Paradex. And then with more research, we knew that this was inhibiting some of the fibroblast cells and disrupting the healing. So when this is left exposed, we don't use any Paradex. So guided bone regeneration. So just to try to keep the lectures more interesting and fresh, because I've been given this thing for 10 years, and sometimes you go to lectures and you see the same person is showing the same lecture they showed last year, and you say, I've seen that slide 10 times. And so this case is literally from 2 weeks ago. So we can see large defect, also sinus defect, not much bone. And so on this case, we do a sinus lift, and I've got a little perf here. So we go ahead and place our Amnion-Chorion to seal the perf. And we can see it sealing the membrane. And this material is outstanding for sealing perf Schneiderian membranes. Because one, it's almost the same thickness as Schneiderian membrane. It's self-adherent. So when you place this, it will literally stick to the membrane. And anywhere that you have a perf, just make sure I'm staying, ooh, God, I'm going to have to start going quick. It seals this and allows things to keep healing. So we go ahead and seal this. We place our bone graft. We place the Amnion-Chorion over the lateral window. Also do a tenting screw and graft anterior to this. This is where our graft is. And then here we are at implant placement. So we see guided bone regeneration. We're able to regenerate bone in the sinus, regenerate bone laterally, and get our implant in. So using this for ridge splitting, here's a case. We go ahead and split the ridge, do a green stick fracture, place our bone allograft, place 1 layer of Amnion-Chorion, no tacking sutures, no anything, primary closure, and here we are after, and you can see where the old ridge cuts were for our implant placement. So here's a combination of GBR treatment with BMP. So here's a patient that has a fairly challenging anterior defect, so in the aesthetic zone, soft tissue defect, hard tissue defect, so it has a very big potential for a very poor outcome. And so what I did was just do an extraction, got our BMP, tunnel up from apical portion, place a bone graft, some BioXclude over the socket, then just use the tooth to make a temporary and bond it into place. Here we are at 1 week, here we are at 3 months, here we are at 9 months. So if we look at where we started from, you can see this has a very big potential for aesthetic disaster. So with no connective tissue grafting, just BMP and some BioXclude, we were able to have a fairly nice aesthetic result that's actually been 180 degrees the other way. So another case, this is a case, patient came in and had been told that she needed hip grafting and did not want hip grafting. And so she came to the office and said, is there anything that you guys can do? I said, well, we can give it a shot, but I can't really promise you anything. So we do titanium mesh, BMP, and this husband and wife team that would come in, got certain patients, and they always come in pairs. The husband and wife come in, and the husband never leaves the side. They're always there. And this particular husband wrote down every single word I said, everything I did. So I said, if I'm using BMP, I'm definitely not using it with any bone because that's technically off-label use. So this is just sponge and titanium mesh. And we know that titanium mesh can be notorious for becoming exposed over time. So I placed a big collagen membrane, and then over the top of the collagen membrane, BioXclude to aid with soft tissue closure. So here we are over time, allow that to heal for 9 months. We then go back and we have what appears to be bone or osteoid. So we go back, open that site. We now have at least some bone to put some implants in. Use bone condensers, and surprisingly, we had fairly decent stability. So I still went back and added some additional allograft. Here we are at 12 months after the initial surgery, and now the patient has a bridge, is able to be restored. And this case is now about 7 years old. I just saw her not too long ago, and everything's still hanging in there. And she didn't have to have a hip graft, and she's a very tiny lady, so she was very happy to avoid that. Another case. Yes? That particular person, she just did not wear a temporary when she went home. She had been without teeth for a long time, and she didn't want a hip graft, so she was okay not wearing that. If she did go out into town, she did have a temporary that she would put in, but she did not eat on it. Just a flipper, yes. So this patient's very interesting. She was going, I have about 12 minutes left, so I may go a little quickly. This patient was going to her general dentist and kept complaining about a loose bridge. And every time she'd go into the general dentist would put some orthodontic resin, stabilize the bridge by cementing it to the tooth next to it, and then about a day later it would break loose and come, and she did that about 5 or 6 times. Then finally she came into our office and said, I think I might have something wrong with my tooth. And so you can see she had quite a bit of bone missing in this area, literally a communication into the nose. And so for this site, we removed the teeth, did tenting screws, bone allograft, Amnion-Chorion, suture. We allowed that to heal for about 4 months. And so here's our bone formation. And we can see that we have bone pretty much to the head of the screws. So then we ended up doing this into a full arch case where we regenerated the bone. And we can see that we put 2 implants in that bone that was regenerated. And then over time, this patient ended up getting a full treatment, and this is now at 7 years out. Okay, so used for sinus lifts. So this patient, for some reason I have a lot of patients from Colombia, not Panama, but patients that I've noticed from Colombia so far in my office have all been over 80 years old and are all very demanding. So this lady had been in a denture for a very long time and did not want zygomatic implants and still wanted some implant teeth. So you can see that she's starting with very minimal bone, about 1 millimeter or less on both sides. So we go ahead and do standard bone grafts. So I'm trying to basically in these cases do as big a bone grafts as I could do. And so here's before and after. We got about 18 millimeters of bone, and before and after 20 plus millimeters of bone. So as long as I'm staying away from the ostium, I'm fine. So we see before and after. We're now able to restore her case. Implants, teeth, before and after. It was very funny because when we first put her first set of teeth in, she was very upset because we put her midline in her midline. And if you notice, this midline's off, and she wanted her midline to match her lower midline on her natural teeth. So we had to change her teeth to match her lower midline, which was this, and then she was very, very happy after that. So that was interesting. Schneiderian membrane repair. So this is another interesting case. So this person had subperiosteal implants placed in 1981. They were removed in 88. He had sinus lifts attempted in 2002. They failed. He'd been in a denture since the subperiosteals were removed in 88. So he's had no teeth since 1980. And this is what he is starting with. So very minimal bone, from 0.5 millimeters to 1 millimeter of bone. He did not want zygomatic implants, so it didn't leave us a whole lot of option. So just going into the sinus, because of all the previous work done, there's already perforations. So we lift the sinus, place our membrane, place over the window, do our grafts. The other side, just opening the flap, there's already a giant hole into the sinus. It's literally like Swiss cheese. So we use our Amnion-Chorion to rebuild the membrane. We pack our bone, and then place a membrane over the window. So here we are before, after on the right side, here you're before and after on the left side, and here he is after. And you can see very minimal bone. There's about 0.5 millimeters subnasally. There was about 1 to 0.5 millimeters in the sinuses, and so we're still able to restore him without going to the zygos. And the patient was very happy, and the Amnion-Chorion had a big part to do with this. Before, after, and here he is nice and happy. And he's about 4 years out right now. So in our full arch practice, we start seeing a few different things. And so here's a case. I put in 5 implants. At the first follow-up visit, there's some infection around this implant. This is spontaneously opened. And so I go ahead and remove that implant, cleanse the area, graft it, place BioXclude, leave it exposed. Here he is at the day of his first post-op. Here he is at the cross mount. So we can see that's completely keratinized over where the membrane was left exposed. And this is the area where we had the infection, and we see we have nice solid bone, and the patient's been restored. So another thing we see in the office is we see a lot of iatrogenically placed implants that patients have in pre-existing that they need removed for full arch treatment. And so in this, we have to take out the implants. And I could tell you that when we took this out, I told the patient we don't expect any changes. You're still going to be numb. In any event, utilizing the protocol from actually the neurovascular bundle surgeries from prostate surgery, we started employing this in our office. And so we go ahead and you can see all these implants sticking into the nerves. These are all the 4 different ones. We take this and we convert it into this. And when we're treating these sites, since I don't have enough time to go into it, but I have published the article on it, so if you want a copy of the article, at the end I have my email, just send me an email and I'll send it to you, how we're treating these nerve injuries with the BioXclude. Basically, we're removing the implant, the offending agent, we're irrigating with dexamethasone, we are placing dexamethasone-soaked Amnion-Chorion, and then placing the patient on NSAIDs afterwards, cryotherapy. And at this point, we have published study with an N of 5, where we've had 5 patients treated in this manner who've had significant improvements in their neurological deficits. Another interesting case, repair of oral antral fistula. In this case, I had done a trans-sinus implant. Patient ended up developing pretty nasty oral antral fistula. So for that, place the Amnion-Chorion over the fistula, do a palatal pedicle flap, advance that over the fistula. And the fistula is closed, but what are we going to do? Because the patient has lost this particular implant. And so in this case, we placed pterygoid implants, right and left to balance out the restoration. Yeah, we can see our pterygoids here. And that allowed us, boy, this thing keeps shutting off. That allowed us to still restore the patient so they don't have to go home without teeth. So using these with zygomatic implants. So here's an interesting case. So this case was treated in town. You can see this implant up near the eyeball and the sinus. And this, believe it or not, is what the patient had been wearing in his mouth for almost 5 years. And he had been to pretty much every dentist in town. Nobody would treat him. He came to our office and said, "You guys are literally my last resort. If you can't do anything for me, I'm going to commit suicide. He said, because I've been living like this for 5 years, I can't eat, I can't smile, my implants are all failing. The dentist that did this, by the way, ended up losing their license because this was just one of many, many, many cases. And so this is what it's like when we take off the restoration, or the so-called restoration. And come on. Okay. And this, let's see if this works. This is pulling the, and so when we did the zygo prep, we made the window for the zygo, went up under the eye, relieved the implant and took it out through the sinus. So this is, I tried to recreate the pattern of what it actually looked like in the mouth, with this one being way up here. And so we go ahead and place our zygos, and then over our window we are placing BioXclude, and then you can see also BioXclude over anywhere else that we're grafting. So we took the patient from this is the day of the surgery, this is the final restoration. So we took him from this to this on the day of the surgery, to this in his final restoration, and you could literally see the tears in his eyes because this man had been through hell for the past 5 years. So one final case really quickly, a very interesting case. So that was an intrasinus zygo prep, and showing how we use the BioXclude for the intrasinus technique. This patient was another patient that had been to a chain clinic in town. This was about 1.5 years worth of treatment. Multiple implants kept failing, they'd put in another one. It kept failing, they put in another one. You can see they left him a present in the sinus, left this implant, or left this tooth down here. So he's been without teeth. He can't wear his teeth because he's in too much pain in his mouth. So he's got pain, he's 18 months of treatment, he just wants everything finished. And so what we do is we took all that out, and this is an intrasinus technique. So we're prepping this, we're essentially doing a sinus lift, and when we do this, many times, sometimes we'll get a tiny perf, and again, we're using the Amnion-Chorion to repair that. We then are placing our implants in extrasinus technique, and you can see that we're lifting this in very much the same fashion as a sinus lift. So this is the zygomatic, this is the preparation of the slot, and you can see that we've maintained the membrane intact. So now when we place the implant, it is not disrupting the sinus. So in this case, we did zygomatic implants, piriform rim implants, vomer implants, pterygoid implants, extending implants to the inferior border of the mandible. So we take this, convert it to this. We take this and convert it to that. He's a very happy patient. So in summary, we can see that this has more growth factors than any other membrane on the market. It can be used for GTR, it can be used for GBR, it can be used for site preservation, sinus lift, membrane repair, nerve repair, rescue operations, a lot of different techniques depending on what the makeup of your practice is. And if anyone has any questions or wants copies of any articles, GTR article, the site preservation article, the nerve repair article, I'm more than happy to send it to you in PDF form. So either contact me by email or on LinkedIn. And I thank you for your attention. And I'd like to also say thank you to all our military members. Thank you. Thank you. Okay. And